everybody, welcome to our presentation of Alexia and Agraphia. Um, we hope that you're staying safe out there and we hope you enjoy this presentation. So just kick back, relax, and let's get started. So this is Sue. She is a 69-year-old woman of Asian descent and she was diagnosed with pure alexia. And we do get into what pure alexia is and describe it a little more in the presentation. So her family is from Thailand, and her culture is very important to her. She loves to cook, and she loved to learn the Thai language prior to her stroke. She is divorced, and she lives alone, but she does have two cats who she loves very much, and she even used to read to them before her stroke. She used to work at a local bookstore and met a good friend, one of her coworkers. Her name is Wendy, and they spend good time together on the weekends. Since retiring, Sue has volunteered as a teacher's aide helping children with their reading at a local elementary school. And this has been one of the hardest parts of her stroke and alexia because she is no longer able to read to the kids. She does have very negative thoughts and feelings toward her stroke, so this is something that we are going to address in the presentation. And besides her reading ability, Sue does function normally and she is able to live independently and safely, and she is able to complete activities of daily living. So now we're going to talk a little bit about Sue's past medical history. So she is, like we said, a 69-year-old female. She is right-handed, and she was referred to outpatient cognitive linguistic therapy 6 months status post, so 6 months after her stroke. Because she fell while shoveling snow. And she had a left CVA in the distribution area of her posterior cerebral artery. So her past medical history is that she does have a history of hypertension and type 2 diabetes. She also has a history of hypercholesterolemia, which is high cholesterol, and a family history of cardiac problems. She hasn't had any significant surgeries, so that wasn't a big part of her history, but she does live a very sedentary lifestyle. All those books, not a lot of exercise. So we did talk about her social history on the last slide a little bit, but she is a college graduate. She enjoys reading and writing. Those are her primary hobbies. And she never received previous speech language services, so she's been living a long time with this problem, and we really need to help her out. Her primary goal is to regain her ability to read to kids so that she can head back to the school and get her participation in there.
Okay, so pure alexia is the same thing as saying alexia without agraphia, and agraphia is something that we'll talk about later in the slides, but it's another language disorder that's often comorbid with alexia. Pure alexia is a disturbance in reading in the presence of relatively preserved writing skills. It's something that we call a peripheral subtype of alexia as opposed to a central subtype of alexia. So if aphasia is present with alexia, if aphasia and alexia are comorbid in a person, that would be the central subtype of alexia. But pure alexia, since it's someone who does not have aphasia, is a peripheral subtype of alexia. And like I said, alexia without agraphia is the same thing as pure alexia. So what it is it's a visual deficit due to damage at the occipital lobe, which we'll discuss in greater detail on the next two slides. But basically, the person is unable to process the visual stimuli of letters corresponding to words and how those letters make up words, so they're unable to read. But they have preserved writing skills, so they're able to write, just they cannot read. So in our book, in the Kleineman-Snelly book, it uses this example of visual representation and lexical root to describe pure alexia. So the example that they give is basically we all are capable of visual representation. So if we see a picture, we know what that picture is and we give it meaning. For example, if I see a picture of a beach, I associate that with the summertime, and the meaning that I would give that is that I'm happy because I like to go to the beach. The lexical root is when we have knowledge of a phoneme and we give that phoneme a letter to represent it. Now we can read and we can write that letter. But without knowing the phoneme representation of that letter, we don't know what it means. So letters in print correspond to sounds that we read. So we know what those letters should sound like based on their phonemical representation. And then we connect this to meaning by understanding what we read. So if we sound out the word bear, air, we associate the B, the EA, and the R with different phonemes, and then we're able to sound it out and read it. And then we might say, well, a bear is associated with an animal, and then that's how we understand what we're reading, and that would be processed in our brain. So people who have pure Alexia, since they have an impairment of visual stimuli, and like I said, we'll talk about this in the next two slides, but that impairment of visual stimuli is due to a lesion on the PCA, which is in our occipital lobe. Basically, they're unable to make those connections between phonemes making up words and the letters that represent those phonemes, and then they're unable to read. So because they have this impairment in the visual stimuli, they aren't able to make those connections of this letter represents this phoneme, and when I sound it out, this word is this, and they can't orally read the word. So that's just an example of how the textbook, the Klein and Mancinelli textbook, describes pure Alexia. So they use that lexicon root being impaired, basically saying that they can't make the phonemic connection of the letter due to the impairment in visual stimuli, and then they're thus unable to read. So Alexia occurs due to a lesion in the PCA, the posterior cerebral artery, which is near the occipital lobe. So we talked about how it's a peripheral issue rather than a central issue for pure Alexia, meaning that they do not have aphasia. So it occurs in the occipital lobe, which we know is where we process vision. So it makes sense that they're unable to process the visual stimuli. Alexia, it's important to note that it is acquired. It is due to stroke or TBI. So Alexia is not something that you are born with. That would be dyslexia, which we'll talk about in a few slides, but it has to be acquired. So it occurs in the occipital lobe, which, like we said, it makes sense because they can't make the connections, the visual connections between letters making up words, so they're unable to process that visual stimuli. So this is a great diagram to show you that it's an impairment in the processing of visual stimuli. So we know that the PCA, like we said, is in the occipital lobe. So the bottom of this picture, that's your occipital lobe, and the top where it says left and right hemisphere is your frontal lobe. So you can see at the bottom, the boxes where the PCA, near where the PCA are located in the occipital lobe are left blank. So these blank boxes represent the lack of ability to process the visual stimuli, such as letters making up words, which is what someone with Alexia cannot process when they're trying to read. So therefore, the occipital lobe does not have the processed word information that would have came from our vision to send to the verbal and semantic systems of the brain in the left temporal and parietal lobes. So what happens is, since that information is not there, the occipital lobe was unable to receive that information because of the infarct or lesion there. It can't send that to the semantic system and verbal systems, which means they can't recognize what they're reading. And it's important, like we said, to note that they can recognize the individual letters and words. So they can see that there's a C, an A, and a T in the word cat, but they can't recognize that that word cat is there. So that's important because it's due to that visual deficit. So it's a processing impairment in the processing of that visual stimuli, and then it can't be sent to the semantic system, and they are unable to recognize what they've read. So we wanted to talk about Alexia with agraphia. This is not Sue's diagnosis. She has pure Alexia, which is completely different, but Alexia with agraphia is something else that we all might see in our lifetime as speech-language pathologists. So Alexia with agraphia is different than pure Alexia. Where pure Alexia, the lesion is at the posterior cerebral artery. Alexia with agraphia, the lesion is at the angular gyrus. So agraphia means being unable to write, where Alexia, we know, is unable to read. So Alexia with agraphia is an acquired language disorder where they are unable to read or write. So they're unable to process the visual stimuli of the words when reading, and then they're also unable to write. This is often comorbid with aphasia. So agraphia is something that a lot of us, we may have seen it in the clinic last semester, or next semester in our medical placements we might see it, but someone with aphasia may also have agraphia where they aren't able to write. So not only in Alexia with agraphia is the patient unable to process the visual stimuli for reading, they're also unable to write, which is the agraphia component.
So, as Emily mentioned previously, dyslexia and alexia are not the same thing, so we wanted to discuss the ways that they are different. So, alexia is when someone loses the ability to read words, sentences, and sometimes letters, with an emphasis on an acquired loss of this ability. So, like Emily said, alexia is caused by damage to the posterior cerebral artery, which supplies the left hemisphere into the occipital and temporal lobes. And alexia is often comorbid with expressive aphasia and agraphia, but in Sue's case, she only has the pure alexia. And then dyslexia is a learning disorder associated with trouble reading words, identifying sounds, and decoding. And this is a developmental disorder. So kids have this very early on, and it is managed in school with tutoring and support. Dyslexia may be a lifelong problem, so many people have to learn how to manage their dyslexia for their whole lives. A couple ways in which they're similar is that both dyslexia and alexia involve normal intelligence, and daily function and participation is maintained and totally fine. And so this is definitely true in Sue's case. And alexia can actually be described as a subtype of dyslexia. But again, we want to just emphasize that alexia is distinct and requires an acquired loss of the reading ability. So here we're discussing agraphia versus dysgraphia, and this is really similar to alexia versus dyslexia in the way that agraphia is acquired and dysgraphia is a learning disability that is developmental. And something to look out for as SLPs is that just like dyslexia, dysgraphia is going to cause a lot of issues for kids later in life in school, since reading and writing is relied upon so heavily, and this is going to definitely cause some problems for kids later. So something else that we found is that there's actually a lack of evidence as to where dysgraphia occurs in the brain. But as Emily mentioned previously, there are studies that have found that it occurs with a lesion in the left angular gyrus. So that's where alexia with agraphia is often found. When it comes to Sue's writing abilities, they are actually completely spared, and she is able to copy, write freely, draw, and spell totally functionally. So she does all of those things really well.
The diagnostic materials used for Sue's case would include screeners and informal measures performed first, including the grandfather reading passage, a short paragraph for reading and comprehension, and the MoCA screener for cognition. Realistically, the reading screener would show concern due to Sue's alexia, and we would therefore move to the RCBA, or the Reading Comprehension Battery for Aphasia, second edition. Additionally, we would use the Aphasia Quick Battery, or AQB, as well as the Communication Confidence Rating Scale for Aphasia, or CCRSA, which is a self-reported measure of confidence in communication, which we would use to supplement Sue's treatment in order to get an idea of her thoughts and feelings regarding her impairment. The Aphasia Quick Battery results show that Sue performs well on connected speech, word comprehension, and sentence comprehension subsections because she is not affected by aphasia. The results also show that Sue struggles with picture naming because confrontational naming is impaired. Confrontational naming is impaired because alexia results from an inability to map letters in a familiar sequence to mental representation of the word. Additionally, The AQB results show that Sue struggles with reading aloud. Alexia affects the ability to identify a group of letters as a visual word with meaning. The next few slides show the results of the AQB subsections of reading aloud and picture naming. It is common for patients with alexia and agraphia to sound out irregularly spelled words with incorrect pronunciations. For example, the word no may be read aloud with the K audible. This is seen in Sue's results in items B, C, D, E, and F. Below you can note the IPA transcriptions of each item. It is important to note that due to Sue's alexia, the responses were delayed and labored as she experiences extreme difficulty with reading aloud. There are three primary routes that can activate the semantic system. One, the visual representation route, which is object or picture. Two, the phonological input lexicon route, which is sound to letter correspondence. And three, the graphemic input lexicon route, or letter to sound correspondence. The visual representation route uses a visual object or picture to convey meaning, and this direct path allows a person to see an image and know what it is. Difficulty with confrontation naming is a result of a breakdown in the direct paths of the visual representation route. Below you may find Sue's results of the picture naming subsection of the AQB.
So these are Sue's scores for the Communication Competence Rating Scale for aphasia. Like we said, it's a self-rating scale that people with aphasia can use to let a clinician, their family, anyone really know how confident they are in different situations. While Sue does not have aphasia, like we said, alexia is a peripheral issue where aphasia is central. Sue does not have aphasia, but there were some items on here that were applicable to her diagnosis of alexia. So since this is a self-rating scale aimed for people with aphasia, Sue felt pretty confident on most of the measures. However, on item 2, she initially scored herself at 90% confident in her ability to stay in touch with family and friends, but then she actually changed her score because since she lives alone due to her alexia, she is unable to read any texts, any emails, any letters from her family and friends, which does impact her confidence staying in touch with them. For item 4, which reads, how confident are you in your ability to follow news and sports on TV? She felt that she was not that confident, only 60% confident, because she's unable to read any titles or headlines on the news despite her being able to watch the news. And then similarly on item 10, she also scored herself 60% confident in her ability to participate in conversations about her finances, because while she understands her finances, she is unable to read any letters that are pertaining to bills or bank statements, so she does need someone to read them to her or help her with that, so that does impact her ability to discuss her finances.
The RCBA-2 measures the severity and quality of acquired reading difficulty. It is only to be used for people with acquired reading impairments. The RCBA takes only 30 minutes to administer and covers many functional domains. There are 10 subtests: word visual, word auditory, word semantic, functional reading, synonyms, sentence picture, paragraph factual, paragraph inferential, and morphosyntax. The sentence and paragraph comprehension, synonyms, semantic, and phonemic confusion shows that this test does have sensitivity because if you have an impairment, you will likely do poorly on this section. There are 10 subtests, and each item is worth 1 point. Each subtest has 10 items for a total of 10 points, and you are to determine the overall score out of 100, 1 point for each correct response. The RCBA can be useful because we would be able to use it as a future assessment. It could also be administered via telepractice or after the quarantine is completed. The RCBA allows for the measurement and nature and degree of an acquired reading impairment and measures reading comprehension, which will aid in guiding the direction and focus of treatment.
So here we're looking at Sue's ICF model, which just describes how Sue's Alexia impacts the multiple facets of her life that are mentioned here. So the health condition is Alexia, and the body functions and structure that are affected is that she has language impairment secondary to left hemispheric stroke in the posterior cerebral artery. The activities that are affected is her difficulty reading, and her participation is affected by her inability to read to kids, as well as read for enjoyment. And I have found that the participation portion of the ICF model is where Sue shows a lot of difficulty because her Alexia is holding her back from one of the only jobs and hobbies that she has, so this is definitely a big loss for her. Her environment is described as very individual because she does live alone and has no immediate family, so she doesn't have a lot of support in the home. But thankfully, she does have a close friend, Wendy, like we mentioned before, and is close to some of her neighbors, so they help her out when they can. And so the ICF model doesn't really give a very in-depth look at how Sue's Alexia really impacts her, just because her deficits are related so much, or just localized to reading. So here it just looks like she's unable to read and just do that, but actually it affects her in a very deep way. Because for a person like Sue, reading is really at the center of her life. So when we look at the AFROM model a little bit later, that'll give us a deeper look into how Sue's Alexia is affecting her. So here is Sue's ALD target model. And Sue has a ton of strengths, which is really great. Her expression and comprehension of orally presented language is totally in functional limits, as well as her writing. So those are totally spared when it comes to Sue. Her difficulties are definitely related to reading, obviously. So here she has moderate to severe impairment. And the way that Sue's reading difficulties present is that she has difficulty with word and sentence level comprehension, and that's compromised due to the slow and inaccurate attempts of her reading. So as she's trying to read out words and sentences, it's really labored and slow, and she also relies on sounding out words letter by letter, so it makes it very difficult for her to understand an entire sentence. And she does have severe difficulty when reading orally, and she often mispronounces words. So just in all forms, she does have trouble reading. But a strength of Sue's is that she is able to read and comprehend short, concrete words that are familiar to her, which is a great start and somewhere to practice. So now we're going to talk about Sue's AFROM model, which definitely gives us a better insight into how much her Alexia is affecting her life. So for participation, it goes a little bit deeper than just her inability to read to the kids and for leisure, because this was her only hobby and vocation, and it was taken away from her. So that really opens up a lot of her day and probably makes her feel bored and lonely. However, she's fortunately still able to spend time with her neighbors and with Wendy, and she can still actively participate in her community and get better involved. So those are options for her, but overall, her independent function is impaired whenever reading is involved. So with cooking and grocery shopping or driving new places, Sue is definitely at a little bit of a loss. So um, she does need to be careful, and that's something that we need to work on with her. Um, so, for her personal identity, her feelings are definitely anger and sadness, and she is less confident when it comes to reading, of course. So, like I said, she definitely is lonely, and she is feeling really bitter with how her Alexia is affecting her life. So, that's something that we need to address as well as SLPs. So, for her language impairments, again, this goes further beyond just her inability to read. Her actual impairment is reading. And this section kind of encompasses everything that the ICF model talked about. So, what is wrong with her and what we need to target with her. So, when we go into this, for Sue, she needs some functional goals that interest her and boost her mood about her recovery because she's a little bit of a stubborn woman, and we definitely need to encourage her and make her feel that all of this is worth it and that it's very functional. So, again, she needs motivation and encouragement regarding her impairment and working toward her reading. But she is a really hard worker, and she does want to get better. So, because of that, she does benefit from more intensive and focused treatment just because she is so eager to improve her reading and she works really, really hard. So, maybe even some take home materials are definitely good for her and additional practice. Therapy can even go into learning new strategies and filling her time now that her reading is so impaired, and stuff like that. So her environment, like we said, she does live alone, which is definitely hard. But the positives of her environment are Wendy and her neighbors. So their names are the Preet family. So she shares common interests with these people and like reading and her culture because the Preet family is also Thai. So with them, that's where she can really get into like the things that she cares about and really get more functional in her community. So things in Sue's environment that get in the way for her is definitely her frustration because that makes her uninterested with trying new things sometimes, and she definitely feels bitter about not being so independent. And what the family, the Preets and Wendy can do to help Sue on the weekends when they spend time with her is like working with her, inviting her over for dinner. That's what they do. And just like doing things with Wendy. So those are all things that they do for Sue that help her get out of the house and get her more involved in the community so that she has an opportunity to practice her reading a little better. So those are all of the things that we need to cover. And this is why we really like the AFRA model because it's an ideal model to base Sue's treatment on. Since her impairments are pretty localized and not so vast, this focuses on elements in her life that have been affected and how she feels about them. So it definitely goes in a little bit deeper than the ICF model and gives us a lot more that we can base our treatment off of. So this model definitely shows us that Sue's impairment is only one little aspect of her life, and there's a lot more that we can work with for her to get her to a more functional level.
So here we're going to talk about therapy techniques that we would do with Sue, or just in general that you can do with someone who has Alexia. So the textbook talks about the restitutive versus the substitutive forms of therapy techniques for Alexia. Basically, the textbook says there's two types. There's restitutive, which is when you're trying to restore the premorbid level of reading and fix the underlying cause. So, for example, this might be forcing the patient to rely on any residual reading ability that they have after their brain injury. Whereas the substitutive model would be providing them with compensatory strategies or using any kind of support to facilitate reading. The Klein-Mancinelli textbook does say you can start at substitutive and then move to restitutive, or they say you can use a combination approach. So some specific treatments that we would use with Sue. The first one is called letter by letter reading, and this is more of a compensatory strategy. But since people with pure Alexia can recognize the letters, they just can't make those phonemic connections and read the words due to the damage in the occipital lobe. What you can do is you can start with print. So only print letters, since script is much more difficult to read, and you have them break down the word into each letter and then sound out the word after they recognize each letter. So you can break down the word at the auditory level. For example, if you gave them the word cat, you would present them with the C separate from the A and the T, then the A separate from the C and the T, and then the T separate from the C and the A. And then since you're breaking it down at the auditory level, they can then sound out C, A, T, which is cat. And this would work since they have their auditory processing still intact and because they're able to identify letters just separate from the words. They can't identify the whole word, but they can identify letters in isolation. So this is definitely more of a compensatory strategy that we would give Sue because it does take a long time, but it's a very basic compensatory strategy and it does work. So the next treatment that we would give to Sue would be multiple oral rereading. So this one is basically you read a passage over and over and over again with them in therapy, and then when they go home, you tell them to read it also at home. So some things that people might assume about multiple oral rereading is that it's just memorizing the text, but this is not true because memorization can be difficult for people who have brain injuries or strokes. So the key is repetition. So you first establish a baseline and the rate of errors that are read to set a target for however many words you want them to be able to read per minute. Then you repeat, and repeat it over and over and over again. So you read it together with them over and over, trying to improve that baseline rate of errors per word set. Then you can assign homework of repetition later. You can assign homework of repetition, and then later in the clinic, you can reassess the number of errors that they have when reading in comparison to their baseline. So repetition of reading and multiple oral rereading leads to generalization of words for other passages. So if they get better at identifying certain words in the passage that you're giving them during therapy and the same one that you're giving them to practice repeating at home, this can generalize to other words that they might be reading that aren't in those passages or that they're trying to learn how to reread that aren't in those passages you assigned. So you basically continue this by assessing the baseline and assigning a new, more challenging reading passage every time the target is met. This is a top-down approach because you start at a broad level of reading passages rather than at the specific level of reading individual syllables and words, and then you practice repetition of reading these passages to work toward generalizability of those words. So basically, this one is another one where you can use integral stimulation at first, where you read it with them, kind of like a form of integral stimulation because you're going to be reading it with them. And then as they get better, you can assign harder passages for them. It's also important, I would definitely make sure the passages that you're assigning and that you're reading with them in therapy are ones that they're interested in, because this is just going to be boring if they're not, passages that apply to their life or passages that they would be choosing to read anyway. You want it to be functional for their life. You want it to be personally meaningful. So you want to make sure that you're choosing materials to use in the clinic that they would use in real life, that they would want to read in real life. So that's really important. You also want to make sure you start with a very basic passage, because if you start with a passage that's, maybe a paragraph long and has difficult words, it's going to be really frustrating for the patient, and you want this to be an experience that they are challenged, but it's also should be one that they enjoy because they get to read things that they would like. So you want to start with a basic passage, and then as they improve and the words are generalized, you can kind of go on from there. Okay, so we sent Dr. Husak 2 different videos that we would like you guys to watch. The one is just a really interesting story about an author who actually had Alexia and was unable to read. And then this one we were going to include in the PowerPoint just because of the whole technology issue. We weren't really sure how to play the video while you guys are watching this. So if you guys wanted to take a moment and just pause this video, go to Canvas, and then click on the link to the video of the woman doing letter by letter reading, then we can come back in a moment and discuss it. So now that you've watched the video, you can see in the video how the woman is unable to read the word key, yet with the help of the speech pathologist, she is able to spell out the word key orally. So she says K-E-Y and then says that's the word key. So this shows you the compensatory strategy of letter by letter reading, where they can, since they can identify the letters in isolation, they orally spell out the letters in the word and then they're able to say the word. They're able to kind of read the word that way. So it shows you that this is definitely a lengthy approach. It should be more of a compensatory strategy rather than one's main therapy objective, but it can also be very helpful because it gives the person with Alexia the ability to read the word by spelling it out letter by letter. So we came up with long-term goals for Sue and short-term goals that contribute to the long-term goals. We tried to make all of these goals very functional and applicable to her life, so they have to do with reading to children, reading books for leisure, since that's something that she enjoys to do, and also things that are just functional in general, such as reading from a recipe, or reading a letter, or reading from a phone book, etc. So the long-term goals we came up with are: Sue will independently read articles and short books for leisure. Sue will independently read functional reading materials such as recipes, phone books, etc. to facilitate her independent living. And Sue will use learned compensatory reading strategies to reduce frustration resulting from her Alexia. The short-term goals that we came up with that contribute to those long-term goals include the following. So while cooking dinner with the Preets, which are Sue's neighbors, Sue will accurately read the lines of a recipe in 4 out of 5 opportunities. When at a restaurant, Sue will order dinner from a menu with 2 or fewer prompts from a companion or waiter or waitress in 3 out of 5 instances. And Sue will present a short picture-based story for young children she created with the clinician to children with fewer than 3 prompts from the clinician with 75% accuracy. And Sue will effectively implement a learned compensatory reading strategy, such as letter-by-letter reading, when faced with frustration of a reading task in 4 out of 5 instances. So we wanted to thank you guys for listening and watching our presentation. We also wanted to just let you know the last 2 slides after this slide are just references, so this technically is our last slide, but we did have some discussion questions for you guys to think about after viewing our presentation. The first one is, counseling is recommended for Sue as part of her therapy plan. Why do you think that this is so important? How can an SLP aid in the counseling process? 2. Aside from reading, Sue presents with normal unimpaired language. Why do you think it could be harder to create goals and activities for someone with a mild impairment versus a severe impairment? 3. What suggestions do you have to enrich Sue's therapy experience? What other elements would you include? And lastly, 4. We talked about the importance of making therapy approaches such as multiple oral rereading personally meaningful. What might this look like for a therapy session with Sue based on her case history? What targeted reading materials might a clinician choose to work on with her? So if you guys just want to think about those, maybe you can post them in your comment in the discussion board. And again, we thank you guys for listening to our presentation.